So, hi everyone. All right, so I think now I'm live. Good evening to everyone. All right, so I think now I'm okay. So let me just see how many people are live at present. Hi, hi, good evening. All right, so I can see few people are live. Soumya is there, Sheetal is there, Tawfiq, Ankit, Vikas, DG, and Ankit, Divya. Okay, hi, good evening everyone. And we have Silden Eiffel also. Wow, you didn't got any other name to be kept, but that's how creative you are. Okay. So, guys, this is Dr. Sushil, your orthopedic faculty at DBMCI and eGurukul. And today, I'm here to discuss with you the PYQs of the NEET PG examination. So, you all know this NEET PG has started in the year 2018, and then since then, I can say there are certain hot topics which have been repeated time and again. But yes, in every year, we have seen a step up in the way the questions have been asked in your any of the exam. All right. So, hi, Krishna, Vibhu, Hanikit, Sri, Chandana, Saloni, Ganesh, 120, Ronak Agarwal. Okay. Rathika, SWM, Dr. Jain, Rajat Gupta. Okay. So many. Good to see you all, guys. So, I hope we are ready to start with the PYQs of orthopedics. So, I hope I am audible, visible very clearly to everyone. All right. So I have with me the PYQs of orthopedics, and I'll be discussing all of them with you. So before I start discussing, I must tell you that the questions which have been repeated, for example, osteoporosis, for example, GCTs, for example, ankylosing spondylitis, posterior dislocation of the hip. So I have not taken them again and again, but yes, all the questions which have been there in your previous year exams, they all have been covered up here, right? So I'll be taking up all of them. Noise आ रहा है विभू, please check at your end. If others can too, please confirm that if there is any noise from my side, because my team has checked very well, and the noise has not been there. The voice was very clear. Okay, so good morning. Okay, so Mohammed Yasir is saying good morning. I think you have just got up to prepare for the whole night. That's great. So guys, let's start with the PYQs of orthopedics. Okay, and let's see what all questions we had. So the NEET PG questionnaires from the previous years. Okay, let's start with that. So I'll tell you how the things have been changing in the recent year also. It's NEET PG PYQ. Yeah, it is NEET PG PYQ. So the instrument below, I'm starting with it. All right. So the instrument shown below is used in which of the following nerve injuries? So that was a question of one of your NEET exam, and I must tell you, you should not only be knowing about the types of instruments, implants, or the splints or the traction. So this is a basically splint. I'll not say instrument. It is basically a splint here. So where do we use this kind of splint? If you can just say, uh, clear hai. Okay. How many year PYQs? All the NEET since the beginning 2018. I'm covering up all of them. Okay. So these are all the splints. This is a splint, and here what the patient's arm or the patient's limb is in which position. So you can see the wrist has been kept in extension and the fingers too are being kept in extension, right? So this is what you call as the cock-up splint, guys. So not only you should know that it is a cock-up splint, you should also know that any splint which is given to any of the patient, they are usually of two types, right? It can be a dynamic splint, it can be a dynamic splint, or it can be a static splint. A dynamic splint or a static splint. Okay. Now in this image, if you see what kind of splint is this the static splint or the dynamic splint? So wherever there is a possibility of movement in any of the splint, you call it a dynamic splint, right? And that has been a very, very specific kind of question which has been asked in your previous year exam. Okay, so do remember, whenever there is a possibility of mobilization in any of the splint, it's a dynamic splint. Any of the splint which has got no possibility of any movement whatsoever it may be, like limb is in fixed position, it is called as the static splint. Okay, for median nerve or ulnar nerve, whenever you are talking about the claws, whenever you are talking about the claw here, whenever you are talking about the claw here, what kind of splint has to be used? It always has to be the knuckle bender splint, right? That has to be the knuckle bender splint. So I'm sure that each one of you, whosoever has taken the class of orthopedics from like any of the institute, I can say, or made their own notes from looking at the videos, you have made that table that which all implants or whichever instruments or splints or tractions are important, right? So there is a table of splint which you all must know, where to use the aeroplane splint, where to use the Dennis Brown splint, where to use cock-up splint, where to use knuckle bender splint, right? All of them should be very, very clear to you. These are straight one-liner question and there should be nothing wrong you must be doing in your exams. Okay, so dynamic and the static splint. Yeah, correct, absolutely. Now see, this is the image question number 2 we have. The image given below is an X-ray of a 22-year-old female. Okay, what is the most probable diagnosis? Very straightforward question. No extra histories, no extra clinical picture has been given to you, and they just simply want to know from you that what is the most likely diagnosis here in this case, right? Now, see, whenever you're talking about lesion, we have always discussed one very basic fundamental of the bone tumors, right? Okay, so let me just yeah. So whenever you're talking about a bone tumor, the approach to the bone tumor has to be very, very clear. What is the basic approach to the bone tumors? So all the time, there are three steps that you have to see, right? Approach to any of the bone tumor has to be very clear. That first step, first thing to be seen is always and always the location. Always look at the location of the lesion, right? Whether the lesion is located at epiphyseal area, whether it is located at metaphyseal area, or whether it is located at diaphyseal area, right? That is the first thing to be always seen in any of the lesion. Second thing is to identify the nature of the lesion, whether the nature of the lesion is benign or whether the nature of the lesion is absolutely aggressive, malignant one, right? And third one is the special feature. Third one is the special feature. Special feature means every lesion, every tumor of the bone, they have got one specific feature which usually it's not seen in any of the other tumors, right? For example, GCTs, the suboptimal appearance, right? The sunburst appearance, the onion peel appearance. So everything is a characteristic of a particular different tumor. Now, whenever you are differentiating tumor on the basis of the location, right? Whenever you differentiate that on the basis of location, you know that epiphyseal lesions, basically we read two. There are certain more as well, which are very uncommon. But yes, two epiphyseal lesions are very, very common. One is what you call as giant cell tumor. And giant cell tumors, other name you all know is osteoclastoma, right? And other epiphyseal lesion is which one? Other epiphyseal lesion is chondroblastoma, right? It is chondroblastoma. Okay, what is the basic differentiating point between these two lesions? Giant cell tumor, it will be seen in the age group of second to fourth decade usually. The people who are kind of skeletally mature, right? There you see giant cell tumor, but chondroblastoma is a tumor seen in children's. So whenever in any X-ray, very simple, I am telling you a rule that in any X-ray you see the epiphysis getting involved, there are primarily two lesions we can see. There are others, as I said, also like clear cell chondrosarcomas, but they are kind of not very common, unusual ones, so you can skip that. But epiphyseal lesions, the two most commonest are the osteoclastomas and chondroblastomas. Chondro, how to remember which one is in a child, which one is an adult? So see, chondro, this is cartilage, right? And cartilage lesions are more commonly seen in which age group? A pediatric age group or adult age group or immature skeleton. So chondro has to be a part of the immature skeleton, right? So giant cell tumor in the mature skeleton, immature skeleton, it has to be the chondric lesion, right? So this one, when you look at the epiphyseal area, here we can see that there is a lesion at epiphyseal area, and in this we don't see any of the growth plate. So when you are not seeing any of the growth plate, it simply tells you that it is a skeletally mature patient, and epiphyseal lesion at the skeletally mature patient, it has to be like going in favor of giant cell tumor, right? That is one easy way. So everybody whosoever like is having a trouble with the bone tumors, I can tell you there is an image of bone tumor, just one page note which is available in the media section of DBMCI Premier Group. You can go over there, download from there. If you don't find it there, just go to my group, the Sushil Orthopedic Discussion Group, and download it from there. So in just one page, you should be able to differentiate which tumor occurs at what location, what nature, what special feature, and the treatment plan. Right? So don't miss out any of these things. The bone tumor is a very straightforward and the very simple topic. Right? Perfect. Okay, so this one has to be giant cell tumor. Okay, osteochondroma will be a polyp-like growth. Chondroblastoma, it should have in the pediatric age group. Aneurysmal bone cyst, again, it occurs at metaphyseal area, right? It occurs at metaphyseal area, and in the metaphysis, if it occurs there at the metaphyseal area, what is the typical feature it produces? Again, the soap bubble. But please remember that soap bubble actually has to be at the metaphyseal area, right? That is a basic difference between these two lesions, right? That is a basic difference in these two lesions. All right. So I hope it is clear. Yes, everybody has answered very, very correctly. Let's see the third one. It was your question of this year only, that recent year 2023 NEET exam, that X-ray of a person was given to you, and he was complaining of off and on knee pain, right? And there is no history of trauma. They said the patient is coming to you with a atraumatic knee pain for last so long, all right? And what is the diagnosis and further management? They asked it. So non-traumatic pain in the knee with this kind of picture. This view of the knee is called as what? The skyline view, right? And in this skyline view, what you are able to appreciate is the lower end of the femur here, this one, is articulating with the undersurface of patella, which is a normal like picture. But then we have some extra pole, we have some extra piece of the patella here, right? So Anjani is saying that it is B, patellar fracture, and we have to go for tension band wiring. You are saying that, but see what they mentioned, there is no history of trauma, right? There is no history of trauma. So trauma, if it is not there, how can the patella be fractured, right? So please yeah, please make it very short to read it very, very carefully. And this one is just a case of a bipartite patella. What exactly is a bipartite patella? Bipartite is basically a congenital defect. Normally, the patella develops as one single piece, one single bone. Sometime, as a part of congenital failure, patella can have two poles, patella can have three poles, right? So, bipartite, tripartite patella, these are congenital defects of patella. So, they don't usually create any trouble because patella, is not a weight bearing bone, right? It doesn't lie in your weight bearing axis. But sometime, if there is a double pole of patella, if with minimal trauma, there might be some impact which may happen. This might cause some pain off and on, some inflammatory changes off and on. So if it is giving some trouble, what we simply do is we simply excise, right? So whatever is creating trouble, we can very well just excise it. So excision can be done in these cases. All right. So this is a case of bipartite patella. All right. That's a case of bipartite patella we have. I hope that is fine. Yes, majority have answered it very correctly, and only few answered it B. So I think you now know that answer is not to be the injury. Next one. A 20-year-old male presented with shortening of the left limb, right? Every word has to be important over here. The male fellow is having shortening of the left limb, right? And multiple swellings in the limb and multiple skin lesions. So we are talking about the skin involvement as well, right? We are talking about the skin involvement as well. Okay, so you should know that whenever, okay, so you should know that. Okay. Now, this lesion, when you look at X-ray of the pelvis is shown here, which is showing us X-ray like proximal femur actually. What is the diagnosis here? Now, when you look at the image here, what you can appreciate, that whole length of the bone is involved, epi, meta, dia, every part of the bone is involved, and bone is bent like this, right? Why the bone should be so soft that it is actually bent? Why it is so soft? Because it has turned fibrotic. And where do we see that? This is seen in the fibrous dysplasia. And you know very well that the fibrous dysplasia, it can be of both the types. It can be a monoosteotic form. Monoosteotic means a single lesion somewhere in the bone, or it can be a polyostotic form. So monoosteotic lesion or polyostotic lesion, they both are possible. Polyostotic means multiple lesion in the same bone, the whole bone, or multiple bones at a time can be involved. That is polyostotic lesion, right? So whenever somebody has got fibrous dysplasia, which is having a polyostotic lesion, whenever this polyostotic lesion has got associated polyostotic lesion with the intramuscular myxomas, right? With intramuscular myxoma. That is a question telling that there are multiple swellings. They are telling you, okay. So myxomas, whenever somebody has multiple myxoma, what do we call that? That is called as the Mesobrod syndrome, right? That is called as the Mesobrod syndrome. So intramuscular myxoma, it has to be the Mesobrod syndrome, right? So polyostotic fibrous dysplasia along with the intramuscular myxomas is called as Mesobrod syndrome. That is what they're telling you, multiple swellings, okay, and multiple skin lesion as well. So Paget disease, why it can't be Paget? Because Paget is a disease of elderly people, right? Paget is a disease of elderly which is occurring usually after the age of 50 years or 55 years in fact. Uncommon disease, not a very common one. So why should I think about the uncommon disease first? Another important point is that in the Paget disease, the most important or the commonest bone to get involved is pelvis. Agreed. But then it usually comes up with a lytic area or a purely blastic area. So in the vertebra, what kind of changes are seen in Pagets? In the vertebra, what kind of changes are seen in Pagets? You know that central part is going to be black, right? This is all black, and all the four other margins of the vertebra, they will be white. And what do you call this kind of vertebra? It is called as the picture frame vertebra, right? So if they have to ask you about the Pagetic disease, they should be giving you more common thing. Osteogenesis imperfecta, that can be one like condition if there is a child who is presenting to you with multiple fractures, right? Child who is presenting to you with multiple fractures, okay. And non-ossifying fibroma, what about that? Non-ossifying fibroma, you know that it is not a tumor, it is not something which is going to keep growing all the time. Non-ossified fibroma is always a developmental defect. What exactly that means? Non-ossified, non-ossified, something which is not ossified, right? And so it remained fibrotic. So this is a development defect, and NOF is the most commonest benign bone lesion. It is the most commonest benign bone lesion, right? Most commonest benign bone lesion. It is a lesion. Please remember, it's not a malignancy. It's not a tumor. It is a most commonest benign bone lesion, right? So this is a developmental defect where the bone has failed to form. Okay, so this is what we are talking about, the fibrous dysplasia. All right, I hope it is fine with everyone. Is there a treatment for bipartite? I have already told you, Vibhu. Okay, this is going. Okay. So, Vibhu, I have already told you what is the treatment for bipartite patella. Bipartite patella, if it is creating some trouble, excise it. Okay. Yes. And now the last point here, it has to be definitely the bending. If it is bending down, what I have to call it? If it bends down like that, then I'm going to call it the Shepherd crook deformity, which is a very, very typical feature of fibrous dysplasia. All right. So that is your fibrous dysplasia resolves on its own. Okay. Which of the following is the most commonest complication of this condition if left untreated? First of all, you need to identify this condition. So when you look at this X-ray, what is the diagnosis we can make out? The diagnosis for this lesion is, this is the proximal part of humerus here, injured area, this is a distal part, and there is an injury here, right? And what is the diagnosis? It is a fracture supracondylar humerus. I hope everybody can identify that, the fracture of supracondylar humerus. And what kind of injury is it? Is it extension type or flexion type? So when you look at the supracondylar, we know that extension types are more common, and approximately 98% cases are extension type, right? Now, when you look at this particular X-ray, the image A, I'm marking here, image A and image B. So in the image A, it is a lateral view, and you can see that the distal part is basically on the posterior aspect, right? If it is on the posterior aspect, so this is what you call as the extension kind of supracondylar injury, right? That's what you call supracondylar extension type, which is 98% of the time you'll see this kind of X-ray. Supracondylar area, you know very well that it is the metaphyseal area of the bone, right? And metaphysis has got what all special features with it? It is the highest vascularity area of the bone. It is the softest part of the bone, cancellous area, highest vascularity area. So breaks easily and heals also very, very easily. Now, whenever you talk about any metaphyseal fracture, if you remember the basic concepts, any metaphyseal fracture, supracondylar, Colles fracture, Smith fracture, Boxer's fracture, Jones fracture. So metaphyseal fractures always have a very good tendency to unite, isn't it? And that is why here in supracondylar, what is the most commonest complication we see? Malunion, right? It is malunion. So malunion always is not bad. Please remember that. Malunion always is not bad. It is good in a way that it has got something good in it. What is good in it? The union part, right? The union part is very, very good here. Okay, so if the union part is good, what is bad? Bad is only the mal part. So if the bone is not uniting in the anatomical position, we are going to call it what? Malunion. As simple as that, right? So union is a good thing, and mal means anatomical, not in the anatomical position. Okay, so metaphyseal, all the areas will be very good, having a good healing power, and because of highest vascularity. So metaphyseal areas, they most often go into malunion, right? That is the first option we have. And most commonest complication, when they're asking you most commonest, it has to be malunion only. Now, which is the most commonest nerve involved in this supracondylis? So please remember, whenever there is a question about the nerve involvement in supracondylar, most commonest has to be anterior interosseous nerve, right? Most commonest has to be anterior interosseous nerve, which is a branch of which nerve? Anterior interosseous nerve will be a branch of the median nerve. And if you want to check for the median nerve, what is the most important clinical test we do? What is the most important clinical test that can be done for anterior interosseous nerve? The flexor pollicis longus and the flexor digitorum profundus. So just ask the patient to flex both the joints and hold it like that. And what do you call that? That is called as OK sign, right? The OK sign or the kilo Nevin sign. OK sign or the kilo Nevin sign, right? So any of the ways the question can be there in your exams, right? Any of the way the question can be there in your exams, right? So nerve involved, AIN. The most commonest complication is malunion, which leads to now what kind of deformity? What you call as the cubitus varus deformity, which is also called as the gunstock deformity, which you also call as the gunstock deformity, right? That will be called as gunstock deformity. All right, so this is your another question of the exam, supracondylus and compartment syndrome. I must tell you guys, please take a note here. The supracondylar fracture, along with the another topic which is very, very important for all your exam, including this upcoming NEET, is compartment syndrome, right? That is very, very important, and I would recommend that these few topics which are repeatedly asked in your exam, you must be very, very thorough with them, right? That is compartment syndrome. So please remember, please recall all the important points of your compartment syndrome. You must remember all of them. Okay. Now, next one. Okay. So we have, which will be the ideal treatment for a closed displaced fracture of, okay, lower third of fibula with the fracture of medial malleolus. Sharp ends were seen at fracture site with soft tissue swelling of leg on X-ray management test. Okay, see, what they are trying to tell you is very simple, that somebody has got a fracture bilaterally, both the sides on the ankle area, medial malleoli, lateral malleoli, both are injured, right? And sharp ends were seen at the fracture site. That means it is poking into the skin area. Now, what you will do? They are telling you it's a displaced fracture. It's a intra-articular fracture probably. What you will do? Close reduction and cast. Neurological assessment you have to do, analgesic, neurological assessment, close reduction, and again check neurological assessment and analgesic. See, what makes sense here is what they are telling you: the sharp ends of the bones were seen at the fracture site with soft tissue swelling of the leg, right? So sharp ends, when they're telling you the bone definitely is compressing upon something, right? Bone definitely will be compressing upon something, right? So whenever some bone is getting displaced and compressing upon the soft tissue structure, we must be very, very clear with this. Yeah, we must be very, very clear with this, that it might be compressing upon some neurovascular structure. There might be compromise. Now if you just give a painkiller and closely reduce and do the casting, you are nowhere assessing the neurovascular compromise that might be happening. So always the assessment has to be done. Option B and C, they both make some sense, but it is telling you, option B is telling you that I'll do the neurological assessment and I'll give some painkiller and I'll close reduce. Right? Closely I'm going to reduce it. Option C says, I'll go for neurological assessment, I'll go for reduction, and again I'll check it. See, what might happen is, initially when you reduce any bone, at that time, any bone which is displaced, if you try to like palpate the vascular pulsations, they might be palpable. After your reduction, the bones, once they are reduced, then they might impinge upon the neurovascular structures, right? So always make it a habit that once the reduction has been done, you must reassess the neurological, the vascular compromise, everything has to be reassessed. Option C makes the best sense over here, right? It makes the best sense here, that you must examine the patient before and after the reduction. Okay, so always make sure that you are examining them. This has been a very, very favorite topic. See, this question has been in relation to the external fixator. So I want to discuss a little bit about the external fixator here. See, when you're talking about the external fixator, how many types of fixators we know? Fixators, external fixator, if you say, number one we know is Elizaro, right? Number one, and I'm sure each one of you is having that file of instrument and implant. So if you have that, wonderful. If not, please download it again from the group and keep it with you. That is in everybody's eGurukul app. So the separate section has been there for instrument and implant, and please go through that section before you go to your exams. That will be very, very beneficial. Okay, so one is Elizaro, one is what you call LRS. LRS stands for what? The limb reconstruction system, right? It stands for limb reconstruction system, which is also called as the rail fixator, which is also called as rail fixator. And the third one is the simple rod and clamps. Third one is the simple rod and clamps, right? This implant, this instrument basically, which has been applied, right? This implant which is there all around the knee area. Now, what they are asking you is what kind of fixation is that? What is the type of fixation? See, whenever any of the implant is like going around the joint, we simply call we simply call it as a spanning fixator, right? We simply call it as a spanning fixator. Spanning fixator, why it has been given? Fracture shaft of femur, fracture shaft of tibia. See, if the injury would have been in femur, we should have fixed only femur. If the injury would have been in tibia, we should have fixed only tibia. And if the injury is into the joint area, that is why you are putting an interconnecting rod, so that you are able to keep the joint distracted, right? So that you are able to keep the joint distracted. And that is why this kind of placement of any of the external fixator, this kind of placement of any of the external fixator, it will be done in case there is an intra-articular injury, right? Fixed femur if it is femoral injury, fixed tibia if it is tibial injury, if it is intra-articular joint area injury, maybe of the lower femur or the upper tibia, like that, this whole zone, then we are going to give a spanning fixator, which is like around the joint area, keeping it distracted, right? So please be aware of rod and clamps, be aware of the LRS, which has been a past PGME question as well, and Ilizaro, definitely, you all know about that. So they're important ones. A patient develops dyspnea and difficulty in breathing 2 days after admitting in hospital because of multiple injuries due to RTA, right? Respiratory involvement is happening. Respiratory involvement is happening after 2 days, right, of admission post RTA. What is the most probable diagnosis? We know that if there are multiple fractures, multiple injuries, most commonest thing that happens usually in the orthopedic department is the fat globules coming from the marrow area of the bone, they get into the systemic circulation, right? So fat globules in circulation, fat globules in circulation, and that is called as what? The fat embolism syndrome, right? And what is the time period when the fat embolus? What is the time period when the fat embolus gets into the circulation? The time period, usual time period is 24 to 72 hours, right? Usual time period is 24 to 72 hours, right? But I must remind you here, in the previous years of your exam, when the fat embolus has been asked, they have given you the clinical scenario occurring in the patient within as early as within as early as 4 hours. So please note that thing down. Fat embolus may come into circulation as early as 4 hours also, right? And what is the criteria that we use to diagnose a case of fat embolism syndrome? It has to be GERD's criteria, right? It has to be the GERD's criteria. And what are the parameters that GERD's criteria contains? GERD's criteria has four major criteria, right? Four major parameters are there. Number one, when there is a decrease in the pressure of oxygen, right? It goes below 60. And second is the respiratory involvement in any form. Respiratory involvement means the patient is getting cyanotic, patient is getting tachypneic, so respiratory involvement in any form. Third, the patient is getting the central nervous system involvement. CNS involvement means the patient is now getting irritable, he's getting confused, he's might be like into comatose state, whatever it might be. Any kind of CNS involvement is a parameter here. And the fourth one is the hemorrhagic patches, the PTKs basically, right? Petechial hemorrhagic patches, which can be seen on the neck area, the chest area, the axillary area. These are the GERD's criteria we have, right? These are the GERD's criteria. Okay, right? So GERD's criteria, any of the one parameter present in your patient, you have to consider that your patient is going into fat embolism syndrome, right? So GERD's criteria, fat embolism, 24 to 72 hours, and it can be seen in the circulation within as early as 4 hours, right? Within 4 hours. Okay, so this is your number 8, fat embolism, a very, very favorite topic of your exam, setters. And you must know that it's a very common entity to be seen in the orthopedic department, sometimes very symptomatic, sometimes asymptomatic, but yes, it is seen very often. All right, let's see the next one. This was a question which was asked in your All India 2017, and then it was again in the year 2021. A 10-year-old child presented with the limb pain, right? A 10-year-old child. So we are talking about a small kid of 10. Pain is there in the limbs, okay, and painful costochondral prominences. And now you know what? Whenever you're talking about the costochondral areas, whenever we talk about the costochondral prominences, you know very well that we have got two differentials for that. Costochondral prominences have got two differentials. One is scurvy. We call it what? Scorbutic rosary, right? One you call it scorbutic rosary, and second one is what you call as rheumatic rosary. Okay, and what is the difference between the costochondral, scorbutic, and rheumatic rosary? That scorbutic rosaries are always and always painful, and rheumatic rosaries are usually painless, right? That is one major difference we have, right? Second thing, second part of the line says prominence with normal bone mineralization. Now, for the mineralization disorder, you also know very well that for mineralization disorder, we have got two conditions, right? For mineralization disorders is of the bone, we have got two conditions. One is rickets, that will be a pediatric problem, and one is called as osteomalacia, that has to be an adult problem. So, rickets or osteomalacia are two conditions where we have mineralization disorders. Age, children, so has to be rickets. But here it is saying that it is normal bone mineralization, so it can't be rickets, it can't be rickets here as well. So painful costochondral prominences with the normal bony mineralization, it will be only seen in one condition, and that is scorbutic rosary. Now another thing I want to emphasize upon, guys, and one another thing I want to emphasize upon. See, sometime you will be able to see these kind of sharp projections, right, in scurvy patients. And what do you call that? These kind of sharp projections are called as the pelican spur. These are called as the pelican spurs or the pelican prominences. Pelican, you know, which video are we talking about? My video you're saying? Okay, I'm not sure what Sarsai is saying. I'm not sure. If I'm not visible clearly, I think so. The session in front of me is going fine. I think it is going fine. So I'm not sure which camera you are talking about to be cleared. If this is one, I can do that. Okay, so I'm not sure. But anyhow, let's continue. Let's carry on. Yeah. Okay, that is Pelican Spur. So please remember the one very, very other important difference other than these two, which I want to like discuss with you. Other than these two, one very major difference you should understand is the difference of white line. The difference of the white line, right? We are talking about a white line appearance of the white line at metaphyseal area. See, the white line in rickets, when white line in rickets is called as the white line of healing, right? In rickets the white line is called as the white line of healing, and in the cases of scurvy, it is called as the white line of Frankel. How it has been described, that is the white line of Frankel, right? So this is the white line. What is the difference in rickets? Please remember, that's a very basic fundamental point here, that in rickets the white line is seen whenever the patient is being treated, right? On treatment, when you start with the treatment plan of rickets, you will be able to see the white line. So rickets will show you the white line when you have started with the treatment plan, right? So it appears with treatment. As you said, no, it is a white line of healing. And in scurvy, in scurvy, the white line is usually a part of the disease, right? The white line is usually a part of the disease. So white line will be always there in a case of scurvy. It will always be there in a case of scurvy, and when you start treating the scurvy patients, that usually disappears, right? So white line of Frankel and white line of healing, that is a difference. So you start treating the fellow, you start treating the child, and the white line appears, your treatment is going fine. Rickets, you start treating the patient and the already present white line starts disappearing, your patient is a case of scurvy. All right, so that is how you differentiate between rickets and scurvy. Both the points are very, very important. All right. Next one. A patient was brought to the hospital with complaint of pain around left hip joint following a RTA. On examination, the affected limb was flexed, adducted, and medially rotated. I can call it medially, right? Or I can call it internally with obvious shortening. That means shortening is very much visible on the patient, right? Shortening is very much visible to the patient. So in that case, they are asking you that what can be the most likely diagnosis of this patient, right? See, attitude based table. I've always given you attitude based table if you have been into the TND program, or else please again go to the media section of the Telegram group, go to the media section and download that handmade note, that in which condition, what kind of dislocation, or you can even use the Instagram videos if you are there, that I've shared one picture of what all attitudes can be seen, what all attitudes can be related to what all pathologies. So that I've shared on the Instagram as well. So you can just see wherever you are comfortable and download that. So please remember, whenever there is an anterior dislocation of the hip joint, in that case, the patient is going to have the abduction, external rotation, and there has to be a lengthening, right? Abduction, external rotation, and there has to be a lengthening, right? Whenever there is a transcervical fracture, we are talking about what kind of injury? Transcervical means it is an intracapsular fracture, right? It has to be a intracapsular fracture. That means the rotation, the external rotation of the foot area, it has to be less than 45 degrees, and the shortening of the limb, because it is an intracapsular area, so it has to be less than 1 inch. It has to be less than 1 inch. Posterior dislocation, posterior dislocation, it has to be adduction and internal rotation, and it has to be shortening, right? So whenever the head of the femur, it rotates back, it creates a shortening in the limb. And IT fracture is an extracapsular fracture. Injury has gone outside the capsule, so now capsule cannot hold it. Capsule cannot hold the distal part of the bone, and therefore the external rotation will be more than 45 degrees, and the shortening will always be more than, okay, it has gone behind me, so I'll be putting here just below this, external rotation more than 45 degrees, and shortening has to be always more than 1 inch, right? The shortening has to be always more than 1 inch, right? That is a basic difference between an intracapsular and an extracapsular fracture. So you all should be very much aware about this. The attitudes of the limb, of the shoulder also, and of the hip also, they are very, very important. So going with the attitude of the hip, what is the diagnosis here? It has to be posterior dislocation of the hip joint. Also, the catch point here, when you're talking about the RTAs, you know that in RTA, road traffic accident, usually the mechanism for the posterior dislocation has to be which one? It has to be a dashboard mechanism, right? It has to be dashboard mechanism. So dashboard injury is the most commonly seen injury in the hip joint, that is creating a dislocation of the hip, right? Posterior dislocation. Yeah, internal rotation is lateral rotation. No, internal rotation is medial side when it goes back. Lateral rotation means it is going into external rotation. Okay, so I hope it is clear to everybody. Let's see the next one. Okay. Following test is performed to assess which nerve. So now what do you assess here? What is being done? So you can see that the patient's hand is like this on the table and thumb is going up in here to touch the pen. So test name you already know. Test name is pen test, right? Why we do pen test? You know that pen test is being done to check for the abduction power of the thumb. It is being done to check for the abduction power of the thumb. And now you know very well that abduction of the thumb will be done by two muscles. Which ones are those? Abductor. You know very well that they have to be abductor pollicis. One, it has to be longus, right? And other one is abductor pollicis brevis. So now when you're talking about abductor pollicis longus, please note down, it is very, very important to remember this. That's the exception we have. I'm putting in red. It is being supplied by radial nerve. It is being supplied by radial nerve. Reason being, abductor pollicis longus. Where is that? When you look at the base of your thumb, when you look at the base of your thumb, you all can appreciate this tendon at the base of your thumb. This, yeah, this muscle at the base of your thumb, this one is APL, right? On the base of your thumb, extensor compartment. So the first extensor compartment we have is being supplied by the radial nerve, and that is why this APL, which is on the first extensor compartment, it has to be supplied by radial nerve. When you talk about the brevis, yes, it is the brevis which is getting a supply from median nerve, right? So abductor power, this test that we are talking about, the pen test, this pen test we are doing for this one, abductor pollicis brevis, right? Abductor pollicis brevis. So please note down, this is also one of the MCQ which is very much required to be understood and learned here, right? So abductor pollicis longus and abductor pollicis brevis. Then the pen test, and when you talk, okay, fine. So following test, pen test, please remember abductor pollicis longus and brevis, and the exception has to be learnt all the time, right? Next one, let's see. A patient is presenting with the pain around the base of the thumb. What are the two marked tendon in the midst? The same one which I showed you here, right? With these two are the ones. Which one are they? Abductor pollicis longus and extensor pollicis brevis, right? So I'll tell you something here, guys. Abductor pollicis longus has got three MCQs for you for your PGM examination, right? Abductor pollicis longus tendon. It has got three MCQs for you for your examination. One, one is about the nerve supply, which I just told you in the previous question. The first one is about the nerve supply, which I just told you in the previous section. It is being supplied by radial nerve, right? It is being supplied by radial nerve. Second one is the inflammation of this tendon. So whenever the abductor pollicis longus gets inflammation along with the extensor pollicis brevis, right? Along with the extensor pollicis brevis, what do you call that? It is called as decurvane stenosynovitis, right? That is called as decurvent stenosynovitis. And third question that APL can be asked sometime is that abductor pollicis longus is attached where? It is attached at the base of the first metacarpal, that is the thumb area. And what is the fracture that it displaces? What is the fracture that it displaces? So please remember the fracture of the base of first metacarpal, Bennett's. So Bennett's displacement is due to abductor pollicis longus. Displacement of Bennett is due to abductor pollicis longus, right? So nerve supply, the radial nerve, inflammation, decurvance, and Bennett's displacement. Now, if these two are displaced, right? These two are inflamed, not displaced. These two are inflamed. What exactly is the clinical test that we do? So you should know both the names. You should be knowing both the names, right? What are those? In the clinical test, first one is ICOF test. Okay, the first one has to be ICOF test and other one has to be the Finkelstein test. So these are two clinical tests which we can do for decurvane stenosynovitis, right? Decurvane stenosynovitis, right? So whenever you're having a patient like this who comes to you with the inflammation around the base of the thumb, it can be very well a decurvance, right? So ICOF or Finkelstein. Please note that if you're given an image in your exam where the hand has been given to you like this, thumb inside the fist and the ulnar hand, the ulnar division of the hand is being shown, it is ICOF test. Finkelstein is simply holding the thumb of the patient and just trying to pull it, right? That is what you call as the Finkelstein test. So Finkelstein and ICOF are two tests which you should remember from this area, right? These are two tests from the uh, this inflammation of these two tendons, the APL and the EPB. All right, these are two. Let's see next one. Patient is presenting with deformity of the finger as shown. In which of the following condition the PIP is involved but DIP is spared? Now, the sparing of the joint, you know very well that where it is happening, it is a DIP. And what is the deformity being shown here? The deformity being shown here is something like this. And this deformity is called as what? The swan neck deformity. It is called as the swan neck deformity, right? This deformity is called as the swan neck deformity. Okay, so swan neck deformity, and what is the name of the other deformity that we see in rheumatoid arthritis? It is called as the Bottineau deformity. So swan neck deformity and Bottineau deformity, right? Swan neck deformity and the Bottineau deformity. These are two classical ones which are seen in the cases of rheumatoid arthritis, right? Osteoarthritis, please understand the very basic fundamental behind this. Rheumatoid arthritis and OA, what is the basic differentiation in them? OA primarily involves the cartilages, right? OA primarily involves the cartilages. Okay, and rheumatoid arthritis, it primarily involves what? It involves the synovium, cartilage and synovium, right? So cartilages, wherever there is a cartilage, that joint can be easily destroyed, and you know that cartilage has to be in between the two bones, right? And that is the reason why in OA, knee is the most commonest joint to get involved. And in RA, it is a synovium, and we know that every joint has a synovium. But there are joints which only have synovium, no cartilaginous areas, and that has to be involved in RA. And that is the reason why in RA, most commonly involved is which joint? The wrist joint, right? That is the most commonly involved area. So swan neck and Bottineau, they occur because of the complications related to synovitis, right? So they are synovial inflammations which create the rupture of multiple other soft tissues like ligaments, tendons, and so on. That is creating the deformity of swan neck or the Bottineau, right? That creates the deformity of swan neck or the Bottineau. All right. Now, in the cases of the psoriatic arthritis, what is a typical destruction of phalanges known as? That is simply called as the pencil in cup appearance, right? That is called as pencil in cup appearances. And ankylosing spondylitis, what does it come with? It comes with the involvement of the spine, and that is called as bamboo spine. That is called as bamboo spine, right? So these are typical changes of different pathologies that we can see in the bones or the hands areas, basically involving the back. Another one, this was similar one kind of question which you can now diagnose very easily. Patient was admitted to ICU 48 hours after the fracture of femur. Saturation on the rebreathing unit was 100%, but SpO2 remains now 60%. Now he's in a state of confusion. So CNS involvement has been mentioned over here, right? CNS is involved, decrease in the PaO2. What are we talking about? We are simply talking about the fat embolism syndrome, right? So ARDS, fat embolism, pulmonary embolism, that is how they give you the picture. Fat embolus can further destroy multiple organs, right? ARDS and all that can be there. But when you're talking about the long bones, we know that it is the marrow emboli which has gone into the circulation. All right. Next one. Okay, another similar kind of question we have. Now, here multiple joints in the patient's hand are involved. The joints involved are PIP, DIP, first MCP, they all are involved, but the wrist area and the other metacarpophalangeal joint, they are spared. Now, what is the likely diagnosis? Like I told you, that wherever you don't have the cartilage, usually don't get the OA changes. Please understand and remember this point very, very well, that whenever you're talking about that the cartilaginous areas or the arthritic changes are happening, we are talking about a degenerative arthritis. If it is trauma, trauma can lead to any kind of arthritis anywhere, right? So this is the reason why OA does not involve the wrist areas, no cartilaginous, but trauma, if it happens to the carpal area, arthritic changes can happen. Rheumatoid arthritis can have the arthritic changes. So arthritic changes due to some other pathology or trauma is different. We are talking about degenerative arthritis, right? So that has to be osteoarthritis. Perfect. Which method of measurement of scoliosis has been depicted in the image? So you know very well that what is the pathology being shown here? It is scoliosis. And what is the angle being measured for scoliosis? It is what you call as the Cobb's angle, right? That is Cobb's angle. And when you talk about this Bowman's angle, Ferguson angle you can leave, but Bowman's angle, you know very well that it has to be seen around the elbow area, right? For the supracondylar, whenever you are reducing the bones, you must see the angle. And Bowler's angle, where do you see? Bowler's angle, and there is another angle that you can see in the same bone that is called as angle of Gissane. Where do we see that? It is seen in the fractures of calcaneum to see that whether the calcaneum is depressed or no. And if you talk about the names of other two angles, one is Kite's angle. Remember the Kite's angle for CTV, the telocalcaneal angle, right? The Kite's angle has to be telocalcaneal angle. And then we have another one. If you remember, for the flat foot, we see the Mare angle, right? Mare angle, it has to be flat foot. It has to be flat foot, right? So Kite's angle, Mare angle, Gissane's angle, Bowler's angle, this Bowman's one, and the Cobb. So six named angles I want you to remember, right? For any of your exam. Okay, child with recent history of fever, lesion with sclerotic rim in the upper end of tibia, right? So when you know that they are already mentioning you that patient is having fever and there is a lesion, okay, so we are most likely dealing with some case of infection. We are dealing with some sort of infection and sclerotic rim in the upper part of tibia here. So we can see the sclerotic rim in the upper part of tibia over here, right? So this is something which comes at like what you call infections of subacute variety, right? These are called as subacute osteomyelitis. And whenever subacute osteomyelitis occurs in a localized form, somewhere some part of the bone is getting involved, when it occurs in localized form, we call it Brody's abscess, right? Subacute osteomyelitis, we call it Brody's abscess. Why it can't be osteoid Because osteoid it has to be eccentric, right? It has to have sclerotic rim, that is true. But then the point is why there should be a fever, right? Why there should be a fever? Fear doesn't match it, right? So none of the other three pathologies given over here, option B and C and D, they don't match with the risk of fever or the presentation of the fever, right? So, okay, this is Brody's abscess, subacute osteomyelitis coming with the fever, lytic area with sclerosis all around the lesion. Okay, most commonly joint involved in septic arthritis. See guys, now this is something which is little controversial. Some of the literature will mention it as a hip, some of the literature will mention as knee, but I can tell you the highest standard literature that is available with us for the pediatric population, pediatric orthopedics, it simply says that Whenever you are talking about the septic arthritis, 48% of the cases of infection of the septic arthritis, they occur in the hip joint, 47 occur in the knee joint, 5% are the only one which are involved in other joints, right? So hip and knee both are kind of equivalently involved. And if it is right now given to you as a recall, but I'm not very sure, was the question asked in the same manner, or was there was something different in this case as well? But yes, if you see literatures, knee will be there in the local guidebooks, hip will be in the some of the guidebooks, but I would prefer to go with the hip area, right? And again, I'm telling you, no controversial things should be here. Hip approximately is equal to knee. Nothing is like a very definitive or a big difference in them. But yes, one thing I would like to tell you, that whenever it is happening in this hip area, whenever the septic arthritis occurs in the hip area, then you must remember this thing. When you look at the hip joint, it is something like this: acetabulum at the head of the femur in a child. So septic arthritis is something which is common in the age group of 2 to 5 years, right? It is common in the age group of 2 to 5 years. Okay, so please remember, whenever the inflammation occurs around the hip area, it can destroy the head of the femur or it can destroy the acetabulum. Joint area are two connects only, right? So most commonest foci to be involved in septic arthritis, it is actually in the proximal femoral epiphysis. Most commonest foci will always be in the proximal femoral epiphysis, right? So please note that thing. In fact, whenever you are talking about the septic arthritis, it has to be actually in the hip area. Okay, so child 2 to 5, it is most common in the hip area, hardly a difference of 1%. So that doesn't actually is make any big difference. But yes, I would prefer to go with hip. I know the answer in certain app it has been given as knee. Some of the local guidebook it might be given as knee, but not to worry. I don't think so. That is something which is very relevant and to be asked again in the exam. So septic arthritis, 2 to 5 years, foci in the proximal femoral epiphyseal area. Foot drop. Now, year 2023, we have been asked like this question three times. All the three exams had this question. Both the ionized set papers as oh, what happened? Both the ionized papers as well as yeah, yes, both the INI set as well as the NEET exam of 23 had asked this question. You know that very well, that foot drop is caused by injury to which nerve involvement. Now here given to me is the PPT. It is mentioning both the sciatic nerve as well as a common peroneal nerve. Right now, I don't think so. I personally am telling you, I don't think that examiner should be giving you both the options together. But yes, it has to occur with both of them and more commoner. Yes, sciatic nerve will also lead to foot drop, because if sciatic is gone, it is L4, L5, S1, S2, S3. That means everything below the knee area is gone. Common peroneal nerve is supplying the same territory in the ankle, basically the dorsiflexus. So not being controlled, if they are not being controlled, patient while walking will have patient while walking will have a failure of the control of the foot area, ankle area, and there will be definitely a foot drop, right? So please remember that it is more often the common peroneal nerve in relation to which this question is being asked. And if I tell you the last NEET exam, the question was asked something like this: they gave you one lower femur, they gave you one upper tibia like this, and the fibula was mentioned here, and they marked the areas A, B, C, and D. It was something like this, right? So it is common peroneal nerve is involved at what most commonest site? It will involve most commonly at what commonest site? So please remember, it is the neck of the fibula. It is the neck of the fibula where the common peroneal is most likely involved, right? So this is how the question has been asked. Okay, so high stepping it, yes. Once there is a foot drop, once there is a foot drop, how the patient is going to walk? Patient is going to walk with a high stepping gait. Absolutely correct. You're absolutely right. Okay, it has to be a high stepping gait. Absolutely correct. Okay, now this is again a very interesting one. Painful arc syndrome is felt during all except, see, first of all, understand that painful arc syndrome, what exactly is the trouble here? This is pain during 60 degrees to 120 degrees of abduction, right? Pain during 60 degrees to 120 degrees of abduction, that is mid range of abduction. And what can be the possible reasons? So please remember that most commonest culprit for producing the pain in the shoulder when you are somebody is abducting the arm, it is supraspinatus. What trouble does supraspinatus can have? Supraspinatus can have multiple issues, like it can have a partial tear, right? Complete tear, when you say complete tear, no, it can always definitely supraspinatus can have a partial tear, Why not a complete tear? Because if there is a complete tear, there is no initiation of the abduction. You know very well that supraspinatus creates the abduction of 0 degrees to 15 degrees. Now, if supraspinatus is gone, if there is no abduction, no abduction means no question of the painful arc, right? So, supraspinatus, it partial tear. Other reasons can be the supraspinatus can have the tendinitis, or the supraspinatus can have the calcification. So, troubles with the supraspinatus, it is going to create the challenges, right? It is going to create the challenges. Fracture of the greater tuberosity, it is also one of the reason, and subacromial bursitis, the bursa below the acromion, it is also one of the reason. Okay, so we are talking about the painful arc syndrome, which is this painful arc syndrome, which is also known as, what else is the name of this? Also known as impingement syndrome. It is called as impingement syndrome, right? It is called as the impingement syndrome. All right. So painful arc syndrome. Okay, it is also called as impingement syndrome because whenever the person's shoulder is being abducted, it goes under the acromion at 60 to 120, and that is the area where it causes pain, right? Where it causes pain. So impingement syndrome or painful arc syndrome is one or the same thing, and the reason, the most commonest culprit has to be supraspinatus. All right, let's see the next one. Let's see the next one. Which of the following attitude will be seen in patient with posterior dislocation? We have talked about this, right? It has to be always adduction and internal rotation, right? It has to be focused upon adduction and internal rotation. I've given you that point already. Next one, which part of the scaphoid fracture is most susceptible to avian? Now, when you look at the distal radius, you know very well that distal radius is something like this. And then we have the bone scaphoid over here, placed like this, right? And then we have the branch coming from the radial artery. The vessel here is radial artery, and branch from the radial artery, it enters from distal pole towards the proximal pole like this. And this is called as what kind of blood supply? We call it retrograde blood supply, right? We call it retrograde blood supply. Okay, so now if by chance there is a fracture of the scaphoid, for which the most common site is waist area, right? Most commonest site of the scaphoid, it is waist area. Now, once the waist is getting a fracture, once the waist is getting a fracture, this proximal pole is going to lose the blood supply, right? So, which part of the scaphoid is most susceptible to avian? So, guys, don't answer that where is the fracture most common. It is avian is more common in the proximal one third of the bone, right? They are not asking about the fracture, where is it common? They are talking to you about the avascular necrosis, where is that common? So proximal pole is the most common site for necrosis, right? Retrograde blood supply. Fallen fragment sign is characteristic of which of the following? Now, fallen fragment sign, a piece of the bone falling into the cavity, you know that very well. It is very, very pathognomic picture of which tumor? It is pathognomic of the unicameral bone cyst, which is also called as simple bone cyst, right? And what is so hallmark, such a hallmark picture of ABC? It will be a expansion of the bone. It is expansion of bone. Which part of the bone? At metaphysis. With septated appearance. Remember, expansion of the bone with septated appearance inside. What do you call that? The soap bubble, right? You call it what? The soap bubble appearance. Okay, you call it what? The soap bubble. We can call it soap bubble, but you know that soap bubble is also seen in where? It is a main picture of which tumor? It is a main picture of GCT. But in GCT, it has to appear at epiphyseal area. Giant cell tumor will come up with soap bubble. They may come up with soap bubble, but most important point here again, it has to be epiphyseal area, right? That has to be at epiphyseal area. And Ewing sarcoma, you know, the bulk of Ewings is seen at diaphyseal area. And what is the typical feature that you can see in the diaphyseal Ewing sarcoma? It has to be the lamellated appearance, lamellated, or also called as the onion peel appearance, right? Lamellated appearance or the onion peel appearance, right? I'm Sumit. I'm going to cover up all the PYQs which have been taken up. But as I told you earlier, there are certain topics, there are certain points which have been repeated, like posterior dislocation has been repeated. Okay, like the scoliotic part has been repeated, the tumor part has been repeated. So we have concised the questions, number of questions, so that every topic is being touched, every topic is being covered, right? So since 2018 till the year 2023, I'm covering up all the topics which have been taken up in your NEET examination. All right. So number 24 we have is you are the intern on duty, and you receive the patient who has been on road traffic accident. Oh, what happened? Right. Who has been on road traffic accident. All right. And for which of the following patient will you urgently call the orthopedician on call? When to call the orthopedician on call very, very urgently? When do you think we should be doing it? Patient with a fractured arm with capillary refill time of 5 seconds in his finger. Okay, that is a delayed capillary time. So we know that there is some vascular compromise which is happening. Fracture with intra-articular extension. Again, important injury. Patient with weakness of the wrist extensor. Patient with weakness of the wrist extensor. What does that mean? That there is a nerve impingement. Okay, so nerve is impinged here. It is. It is going to be intra-articular fracture. It is going to be the arterial compromise, right? It is going to be a arterial compromise. And fourth one is patient with more than wound more than 10 centimeter over the fracture site. So we are talking about a open fracture, right? Now see, when you are talking about this kind of questions, okay, patient with weakness of the wrist extensor, I think that all of them are the emergencies. All of them are the emergencies, isn't it? But you should always be aware that which one of them is going to cause a irreversible damage, right? Patient with weakness of the wrist extensor means the nerve has been compromised. Now nerve can be compromised because of two reasons. Now out of all these three, definitely the most important one I'll choose as the emergency is an open fracture. But then there is an arterial compromise also, there is a nerve compromise also. In the arterial compromise, more than 5 seconds of the capillary refill time is happening. It's kind of 5 seconds. I know it is a delayed one, but it is still happening. The one with the irreversible damage, weakness of the wrist extensor, why it is there, I would like to know the reason, right? Why it is there, I would like to know the reason. If it is a nerve compression, then I'm not much worried. I can reduce the bone well and I can explore the nerve and I can release it. I'm not much worried about that. But by chance the nerve compression, they are trying to tell you that it is happening after the edema, right? If it is happening after the edema, if they are saying like that, and then I have to think about the possibility of compartment syndrome. So in your exam, if they are giving you about compartment syndrome, this question in your exam actually was in relation to compartment syndrome, where the third option they mentioned was not of the wrist extensor, which is mentioned here. I can tell you that. The third one was when the patient is having pain on passive stretch. That is how the option was there, right? So pain on passive stretch, the pain on passive stretch, right? That was the option given to you. So in your exams, if they're talking about the possibility of compartment syndrome, that is going to be the most important thing, right? Compartment syndrome is going to be the most important thing. Please remember that. But yes, if you ask me, looking at the language of these four options, then definitely the option A is also emergency for me. Option D is also emergency for me. Option C is one. But yes, A would be my first choice. Out of these four given options with the same language, I would like to go with A. But as I told you in the exam, it was about the passive stretch, which tells me about the possibility of compartment syndrome. So then I'll go with the possibility of compartment syndrome. So if compartment, go with compartment. If not, go with the arterial compromise. Right? All right. A patient with a history of fall on an outstretched hand will most probably have injury to which of the following marked areas in the image. So always and always remember that most commonest fracture that can happen to anyone at any given age is Colles, right? Most common fracture at any age group, it is always Colles fracture. Okay, no doubt in that. There should be no doubt in that. At any given age group, the most common fracture always has to be the Colles fracture, right? That is another one. All of these drugs inhibit the resorption of the bone, except all of these drugs inhibit resorption means they are working on the osteoclast. They are working on the osteoclast. Okay, they are working on the osteoclast. All right. So out of these, you know that strontium basically has got a dual action, right? Strontium has got a dual action, and teriparatide is a rank ligand inhibitor, right? It is a rank ligand inhibitor. So out of these, if I have to choose one, if I have to choose one, rank ligand inhibitor is going to do what? It is going to inhibit the activation of the osteoclast, right? So out of them, this dual action drug strontium is the one. Strontium is the one which has got a dual action. So all of these drugs will inhibit the bone resorption. That is why definitely they will be working on the osteoclast. But yes, rice you know very well that this has to be bisphosphonate. Rice has to be bisphosphonate. Okay, and the drug, all of these drugs will directly inhibit the resorption of the osteoclast. But yes, when you give teriparatide also, it is going to be helping in the, oh my bad, sorry, my bad. I have written it wrong, not the rank ligand inhibitor. My bad, sorry. So I just missed it to be mentioned. So teriparatide basically you know that it is a synthetic PTH. My bad, I have mentioned it wrong. So it is a synthetic parathyroid hormone which will increase the bone formation, right? Which is going to increase the bone formation. Okay, which is going to increase bone formation. And the rank ligand inhibitor, which I mistakenly like mentioned here, when you talk about the rank ligand inhibitor, right? We are talking about which drug? Then we are talking about the denosumab. Okay, then we are talking about the denosumab. Okay, it happens sometime. Sometimes we get so tired that denosumab can be thought to be missed by the teriparatide, but it's always to make a correction. All right. So teriparatide, the synthetic PTH, it is helping in the increase in bone formation. Right. PTH. Yes, you are right. Absolutely, you are correct. So it is a PTH. Yeah, synthetic parathyroid hormone which helps in the growth of the bone. Okay. Tom Smith arthritis, the same thing, the septic arthritis of infant. What is Tom Smith arthritis? Septic arthritis of hip in infants. Okay, it is septic arthritis of hip in infants. Okay, infant means anyone who is less than 1 year of age. So most commonest site, we have drawn that picture, I've shown you that picture. So it is the capital epiphysis of femur only. Okay, multifocal is this osteomyelitis is related to. See, whenever some child is having osteomyelitis which is occurring in multiple areas, it tells you that the immunity of the patient is very very poor, right? Immunity of the patient is very very poor. Now whenever you are talking about all these options, sickle cell is one of that condition in which the patient can come up with multifocal osteomyelitis, right? It is coming up with multifocal osteomyelitis. But sometime I can tell you guys, there are syndromic associations as well. When other than sickle cell anemia, it can be Cepho syndrome also. Sometimes there can be Cepho. What is the Cepho standing for? What is that Cepho standing for? You should know. You should be knowing about this thing. Okay. So S is standing for synovitis. The patient will have synovitis. Then patient is having acnes, right? Then there is pustular or pustulosis. I can simply say pustulosis. Okay. And then we have the patient with the thickening of the bone. It is called as hyperostosis, and at last there is inflammation of the bone as well. Osteitis. So synovitis, acne, pustulosis, hyperostosis, osteitis. Whenever the patient is having multiple, associations of multiple areas, then even multifocal osteomyelitis can be like a part of it. But yes, the more common reason I can tell you, both of them, Cepho also, sickle cell also, they both can come up with this, right? So I don't have any one to choose here because the incidences are not mentioned in the literature. So yes, Cepho syndrome and sickle cell, both of them, they have to be like the correct one. So what is Cepho? I have told you, the patient suffering from synovitis, acne, pustulosis, hyperostosis, and osteitis at a time. They are all uh, read under the head of Cepho syndrome. Okay, so fine. So yes, better answer I would choose one is the sickle cell. Okay. Next one is a 25-year-old male having pain and deformity of the tibia as shown in the X-ray, and he has history of trauma 2 years back. What is the most probable diagnosis? All right. Now, what do you appreciate here? Can you see this piece of bone? Now, this is something very very important. It was the 2018 I think MCQ, and then it was repeated again in the very very recently conducted INI set examination. Okay, image of chronic osteomyelitis, right? So what I pointed out is a sequestrum, which is, you know very well that it's a hallmark for your chronic osteomyelitis, right? It is sequestrum. It is the sequestrum, you can see, right? So don't mark this wrong. 4 years back in your NEET examination, 4 5 years back, and now in the recent year examination of the INSET. Recently, what I'm telling you, May 2024. Okay, so this is sequestrum. You can see pain, deformity is there, and it is all trauma was there, and after trauma, there is a piece of the bone which has come up into the bone. But this is not how usually they give you the exam question. Usually, they will be giving you some history, some discharge is there, some swelling, pain, fever, something has to be there. All right. So this is one. Then we have in fasciotomy for compartment syndrome, which structures are released? Compartment, I'm telling you, it has been asked number of times. So for that compartment syndrome, every structure has to be released till deep fascia. You have to go till deep fascia, right? So in fasciotomy, compartment syndrome, we have to cut all the structures: skin, subcutaneous tissue, superficial fascia, deep fascia, everything has to be resected. All right. And perilunate dislocation, how to define that? So periphery of the lunate will be you can say dislocated. Okay. In this case, the lunate may stay on the position and others will dislocate. Okay. Yeah. Or if they say that the lunate is displaced volarly while carpal dislocate dorsally, that is also true. Okay. So looking at the two statements here, the statement A seems to be okay. Option D also seems to be okay. But it is actually lunate when they say displaced. It is not displaced. Right? Lunate has two options. Whenever there is a perilunate dislocation, whenever there is a perilunate dislocation, lunate has got two options. Either it stays normal, or it is displaced, or it is displaced, or I can say instead, actually, I'm writing it like that, but it is not displaced, it has to be like subluxed. It is not usually displaced. The lunate either stays on the position or it is subluxated volarly. Both the things are possible. Okay, so choose the statement which is given to you in the exam. Lunate is staying on the position. Yes, sir, it is staying on the position. Can it be subluxed volarly? Yes, sir, it can be subluxed volarly. But the most important point is that all the other carpals they go dorsally. All the other carpals they go dorsally. Yes, lunate dislocation. Then it is spilled teacup sign. Okay, with image, if you want to see, let me just show you the image as well. Let me just open up. Let me just open up this trauma. Let me show you. If you want to see the lunate and perilunate, let me show you this one. Look at these. I hope you all can appreciate the pictures here. Okay, so normal picture. This I can share in the group also if you want. Just let me know. So see, a lunate, normal lunate, how it looks like. You all can appreciate this one. So this is the lower end of the radius, and there you can see the lunate here, right? Rest of the carpals are in the straight line. Okay, when the lunate will dislocate, look here what happens. The distal radius, the distal radius, all the carpals, but this lunate is standing out, right? The lunate is standing out. That is called as the lunate dislocation. And when all the other carpals, see this, the radius, all the carpals have gone dorsally, and lunate is still trying to articulate with the distal radius. So lunate may stay on the position or it may be slightly volarly subluxed. That is called as the perilunate dislocation, right? That is what we call perilunate dislocation. Okay, so that's how we make a difference. That's how we make a difference. Okay. Yeah. So that is how we make a difference, and that is what I have for you from the last one. All right. So these are all the questions, guys. These are all the questions for your previous last years, the topics which have been repeated. And I'm sure orthopedics will not be that difficult for any one of you, right? It's going to be very, very easy. Apply some basic knowledge, apply some basic conceptual, insight that you have about the subject. And I can assure you, orthopedics will never be wrong in your exams. And you all are going to mark every single question of orthopedics very, very correctly. Not only ortho part, why only that? The integrated part with anatomy, the medicine part, the radiology part, everything has to be like super correct. Okay, so just keep going. Still, we have a lot of time. So whatever subjects or whatever topics you might be weak in, I'm sure you're working on them. You've figured out them well. And if you require any kind of academic assistance from my side, feel free to just inform me, and I'll try to do the best I can for you. All right. So yeah, correct. Right. So all the very best to all of you. And I'm just waiting to hear from all of you after your exams. Right. And just all the very best and just keep going. Right. Thank you so much, everyone.